Hello.
Yes, yes, bhai. सुनाई दे रहा है.
Okay. So without much delay, I think we should start now. So I'm going to introduce today's speaker, Dr. Vikar Ahmed sir. So he needs no introduction among pain specialists, as he is a very dynamic pain specialist who is much enthusiastic about MSK ultrasound, and he has been already certified in interventional pain sonologist by World Institute of Pain USA, and he has trained a lot of pain specialists in various national and international conferences, and he's expert pain specialist is with special interest in MSK ultrasound. So today's topic is sonopathology of shoulder, where he will be discussing on all the pathological conditions in the ultrasound scanning of the shoulder, and we can have 15 minutes of discussion after the session. So without much delay, I would like to hand over to Dr. Vikar sir to start his session. Thank you.
Thank you, Devashish. Good evening, everyone. I think everyone is done with their work for today. So, I would like to thank Academy of Pain Physiatrists to actually invite me for an interesting talk. Definitely, shoulder is something which we all very frequently get, and we always restrict ourselves for only interventions. So, it's important for us to, and ultrasound in shoulder is such that it has a very vast applications. It can be from picking up the abnormalities to treating it. And because we have got the angle of dynamic ultrasound, where even in MRI it is not there. So it definitely helps to pick up many things. So this is the topic given to me. And this is where I work. Basic introduction. I think he's given an introduction. I work at Elevate Pain Clinics, Bangalore. Basically a anesthesiologist. So starting off, always for ultrasound, before we pick up any type of sonopathology, it's very important for us to know few steps, which I always tell that when you start scanning, you need to know your surface anatomy. You need to know your anatomy. You need to know your sonoanatomy, then sonopathology, and then comes the interventions. So when we start off with shoulder, it's such an area where there can be a lot of variations and it's very mobile area, mobile structure. So most important of the structures in the shoulder are the rotator cuff, as we know. And these are illustrative diagrams, which I've taken from one of the textbooks. And also it helps us to know like coronal from anterior and posterior view. And this is a sagittal view. So how your rotator cuffs are actually placed. So anteriorly, we have subscapularis, which comes and attaches to your lesser tubercle or tuberosity. There you have your biceps tendon, this is the intraarticular portion of it. This is a coracoid process anteriorly. These are all very important structures when we are actually coming to the scanning of shoulder. And also superiorly, you have got your acromion, you have got your clavicle. So here also, if you see that the clavicle is slightly anatomically placed higher, so which is also useful for our scanning of the AC joint as well as for interventions. And in the sagittal view, again, anteriorly you've got subscap. You have got three facets of your GT, greater tuberosity, where you have got your supraspine. Again, we need to understand one thing is when we say facets, it doesn't mean that A point to B point is supraspinatus and from B to C is actually infraspinatus and so on. There is a lot of overlap in their attachments. That's the reason why when we are scanning also, there can be an overlap. And this asterisk is basically your biceps, long head of the biceps tendon. Posteriorly, this is the attachment of your infraspinatus and teres minor. So this is again a picture which shows your bursa, and bursa, one of the largest bursa in the body, and it's a potential space. Basically, it's not that in every case we are going to see that the bursa will appear to us, but it's a potential space in which there can be inflammation, there can be fluid accumulation. This is also a potential target for all of our interventions as well. So coming to some basics of sonoanatomy as well, and this is your anterior, how we are actually going to start. I always tell this is the home page. This is where we start the shoulder scanning, and where you place in on the transfer scanning. And you will actually be able to see two hills, that is your GT, which is lateral, LT, which is medial, and you will see the biceps tendon. If you are not able to arrive at this location, you can start way inferior, where you can see the humerus, and you actually scan up as you go, wherein you'll have a flat, inverted C or U shape, which will transform into this. So this is one way of starting your scanning when you're starting your scanning. So the structures which are going to see here is, I've just compared both. So here you have the transverse humeral ligament, you've got the biceps tendon. Biceps tendon can have different, based on your angle, it can look hypoechoic or hyperechoic. If it looks, generally it should look hyperechoic or whitish. If it doesn't, that means your probe is not placed properly, and probably slight caudal tilt will actually make it appear better. So if you go medially, you can see a part of the subscapularis also appearing there. So on the top, you have actually got your deltoid, subcut and skin. So this is again an anterior picture, which is very important for us because your coracoid is there. So this is a coracobrachialis. A little above here, you will actually see the your coracoid process. And anteriorly, you have got, what is this? That is the reason why we say that subscapularis comes and attaches to the LT, and you have got the deeper fibers of the subscap, which are actually in continuity with the joint capsule. So whenever you're going to take a proper, especially if you've got a thin individual, so you are actually going to take quite a lot of external rotation. At that time, you will be able to visualize this very easily. But again, coming down to there is something called a shat block, which we give here at this anterior place. And this is not possible many a times. Of course, it's got its own benefits. It gives you better results in hydrodilatation. But unfortunately, we need more external rotation, which will not be possible in most of our frozen shoulder cases, because it's the very important that you will not be able to give them most of this frozen shoulder patients who are having severe adhesive capsulitis. You will not be able to give a lot of external rotation. So coming to the scanning of your long head of the biceps uh, and the supraspinatus. So long head of the biceps, when you move a little more medial, you can see here the comparative thing where the patient is placed. Usual my scanning or my interventions are all in supine position. And here, of course, it looks like the patient is sitting. So, and in modified cross position, when you go medially, you're actually seeing the long head of the biceps. Then you see a little bit a part of the bursa, you see the deltoid, and you also see a little bit of cartilage there. But when you come translate the probe slightly more lateral, then you see the bird beak appearance of the supraspinatus, which is there. And that star mark is basically thin line. In this case, probably the bursa is not involved so much. So again, this is for your rotator cuff interval. What you can do is you can start from the biceps, track only the long head of the biceps as you go. So your shoulder, you track up, and as you go up, you just visualized or try to visualize your long head of the biceps well. So automatically your probe position becomes slightly in that way, like how it's shown there. So and you need to see that the groove is flattened. So you saw that at the level of the bicipital groove, there was a groove. You have to observe the groove to be more flatter. So this will be the area of your rotator cuff interval, an area which you will be targeting for anterior approach to the joint, because you know that long head of the biceps goes intra-articular. That's where the involvement in cases of your slap tears and all happen. So that's also a reason why, if you, it's many a times wrongly diagnosed as an effusion. So as we go on, I'll discuss about that. Here the important structures, because it's a ligamentous plane, here there are a lot of ligaments which are there. So you see a subscapularis medially, you see that space around, and you see the superior glenohumeral ligament, and there is also a band which goes under, it's not mentioned here, that's your rotator cable. So you see supraspinatus, as you go, you will also see infraspinatus below. And above all, you have got the bursa. So here also you can see that thin bursa there. So now coming to your, in sitting position, it's definitely easy to visualize the AC joint, but any of our procedures, you have to keep the patient, the probe position in your coronal view. Only then will you actually be able to appreciate the AC joint well. And what is below the AC joint, here very beautifully it is illustrated, is your SASD bursa and supraspinatus tendon, which you can visualize through, especially if your AC joint is slightly widened. There are a lot of variations in AC joint, not that every widened AC joint is involved, unless and until the patient has got something, as we say, sonopalpation. You also palpate with your probe. Even you can give a little bit of pressure and see. If that area is involved, that is where you intervene. So this is just a scanning with on volunteer. So you can see here is the AC joint. I've translated my probe slightly more lateral, and you can appreciate, I'll play it once more, the supraspinatus going below. So if there is any impingement here, there will be buckling of, and there will be your your SASD, bursitis will be there. So this is again a position for placement for subscapularis, how you're actually going to visualize. Coming to now, we are actually coming to the pathology. So if there is any impingement syndrome with supraspinatus, tendinosis, here there is no great tear, difficult to treat, but you can actually see that the echo texture, it's more blackish. You can see there is a thin bursa, because the problem here is at cellular level. So the the actual value of your PRP therapy in this is little limited, but yes, you can inject in acute cases. You can inject small dose of corticosteroid and also PRP later on. So this is again how, sorry, yeah, this is again an illustrated diagram on the left, where you can see one is basically your acromion. So below that you have got your bursa. You have also got your supraspinatus, and there is partial thickness tear. So the tears can be of three types. One, where the tendon comes and attaches. Either it can be at the attachment site, which is involving where it articulates. So that is the articular surface tear. In this case, it is a partial thickness tear. Partial thickness tear is the place which we actually can intervene, because these complete thickness tears may not respond greatly. Of course, in geriatric patients where there is complete thickness tear, 80s and 90s, we usually get at that level. Maybe a small bursa injection should do well. Here you can see the normal echo texture will be, it will not be there. The normal echo texture, when I say the fibrillary pattern or the white and black and gray lines which were present in other areas, you see a very typical presentation here of the subscap. This typical, the ecotexture will be not present. And you also can see here that the GT, the bone seems fine. So there is no irregularity, cortical irregularity as such, which we can appreciate. And then there is below that you have got your joint capsule and articular cartilage. So this is a remnant tear where there can be a portion of an intra-articular with a little bit of articular as well. You can also compare it with an MRI findings. This is a full thickness tear and the amount of retraction is appreciated. Here we also call something as, you can see that naked cartilage sign. You can see the cartilage very well at that area where your thickness tear is there or full thickness tear is there. Again, any thickness tear has to be appreciated in both a long and short axis. In most of the places, not alone in shoulder, it has to be present both in long axis and in short axis. So the tendon. In this case, when you have a patient with adhesive capsulitis, as I showed you earlier, so sonopathology here you can compare that the arrows, the open arrows are all showing your CHL and superior glenohumeral ligament. So in this case, it is quite thickened and inflamed, which is a very typical finding of adhesive capsulitis. Here also the coracohumeral ligament at the level of coracoid is thickened. You can see a normal one on the top and an abnormal thickened CHL below. So, sorry. So, yes. So, This is restricted external rotation. So when we are actually going to appreciate at the level of biceps, we go a little medial in transverse plane, and we actually appreciate. If you are not able to appreciate the coracoid, probably you're more inferior. So you can translate the probe more superiorly, where you can see the shadowing and the coracoid process, because below the bone we will not be able to visualize anything. In dynamic scan, place the probe at that level and we can do an external rotation. There will be definite restriction. You can see in A and B. This is a normal external rotation, start and end. Whereas below in C and D, you can see that restriction of the movement is there. So this is also very typical of external rotation, your adhesive capsulitis. Coming to bursa, bursa is again a very big space. We are only seeing a cross section of it. So here you can see bursitis on the left side. It's the textbook picture. On the right side, you can see some synovial thickening as well. This much of collection I have hardly seen in a few of my patients. When you see this, it is not mere as collection. You have to also have an MRI to back up. Probably there are other things also involved. It could be your systemic diseases. It could be your bursal surface tears. It could be arthritis, so inflammatory arthritis also. So all those things have to be ruled out when you see a picture like how you're seeing bursitis with synovial thickening. Yes, of course you can decompress and the patient feels better, but the patient, you have to mention that it's going to get collected once more. So till the time we actually find out the cause, the root cause of what exactly is the problem. But usually it's associated with a bursal surface tear. So here again, this is a biceps tendon. How what you can see on the left side, first picture, you can see tendinosis, and it looks uneven. The echo texture is different. In the middle, you can see a partial thickness tear, not very common to find. Complete thickness tear is common. You can actually, that's the reason whenever a patient you are having a doubt, strip the patient completely and see to it that when your biceps tendon is completely cut, there's something called as a Popeye sign, where your biceps, the muscle would have translated or moved more inferiorly. And this is tenosynovitis, where fluid collection is there. Large amount of fluid, you cannot say it's only tenosynovitis, because there can be a back pressure coming from your joint also. So this is again a huge collection where the star picture is shown, where your biceps tendon in short axis is seen at the bicipital groove level. There is deltoid above. There's quite a lot of collection within. This is again in short and long axis, tenosynovitis can be appreciated. So definitely we can inject at this level. The patient will definitely get good response. But if repeatably it gets, then we have to also think about intra-articular pathologies. This is subluxation of the biceps tendon, very well appreciated on dynamic scanning. You can visualize the subluxation very well on that. So this could be because of involvement of the THL, transverse humeral ligament. This is glenohumeral joint effusion on the left side. You can see that there is some amount of collection. The yellow line points towards your glenoid. A little bit on the top will be your glenoid labrum. But you also can see that the effusion is with uh, the the humeral head is quite even. There's no cortical irregularities on the left side, whereas on the right side you see cortical irregularities. And also, if you can appreciate the fluid, it's mixed echogenicity. So usually this is a case where on the right side it is rheumatoid related, on the left it is not. So you'll see cortical irregularities and erosions in cases of rheumatoid. And in on the right side, the picture as it goes, when you are going to put a needle into the joint, you may not be able to aspirate a little too much. You expect in rheumatoid that the fluid collection looks probably like 40-50 ml, and you will not be even able to aspirate 4 ml. So this is most of the times one long-standing arthritis looks dirty picture. Usually it is inflammatory, and the fluid which comes out, you can very well make out the most of the common straw colored yellowish color fluid is very common, but whitish, thick, yellowish, these are all inflammatory signs, and you have to send it for synovial analysis and culture. This is again the irregularities and the erosions which I was speaking of on the humeral head, which can be very commonly associated with rheumatoid arthritis. This is called as Gazel sign in those cases because it's all in continuity. This is if I just have to say that when previously ultrasound was not very commonly used, there was something called as a triple injection, wherein they used to go in fluoroscopy into the AC joint, through and through the AC joint into the bursa. They used to deposit a little bit of dye and check if they are in the bursa, then also into the supraspinatus and directly into the joint. So this also shows a reverse phenomena where the fluid which is there with direct complete thickness tear of your supraspinatus, the fluid can seep out through the joint capsule into that space and again through the AC joint. So you will find a pseudo tumor near to the AC joint. So on the right side, what I show you, it's well depicted here. It's of course a textbook picture. So coming to calcification, babotage. So there is pre-calcific, calcific, and post-calcific stages. So depending on how painful the patient is having and which stage it is, especially if you don't have any shadowing of the calcification, you can definitely go in for a barbotage. So we put a needle into that area in very small amount. We inject local or NS and draw it out. So this calcification actually, however small it is, can cause pain. So it is very subjective. So coming to little bit of interventions in the joint. So here the key here is you can see that the GT is down because if your the sonoanatomy part which we were covering, if both are equal, then we targeting this area becomes slightly difficult if GT is higher up. So what I have actually done here is my linear probe I'm using. So for most of your for people who are really new to ultrasound, I would also like to say that this is a high frequency probe which is linear, where your needle has to be parallel to the probe. If this consider is the probe, if this is a probe, you have to have your needle parallel to it. If you're at an angle, you are not going to visualize the needle well. So what I've done is I've taken slight amount of, this is a neutral position. I've taken slight external rotation to get the GT down and LT up so that my needle can be, I'll just show you the video is there. The needle can be actually targeted to that level. This is a 26 gauge needle which I'm using, and the needle tip is also visualized. You can see this, that's the transverse humeral ligament, and I'm just trying to avoid the circumflex artery and get into that area. So this is about long head of biceps injection. You can see a part of subscapularis also here and the deltoid on the top. This is AC joint, as I was telling you. So the acromion is slightly lower than the clavicle most of the times. Sometimes you will have large osteophytes. In those cases, you can't come in plane. When I say in plane, the whole needle will be seen. If you're coming out of plane, the needle will be seen only as a dot. So initially, whenever you start off, it's always better to start with in plane because out of plane, the problem is you may overshoot, yet you may see the needle as a dot and probably you've gone way ahead. So that's the reason initially when you start off, but AC joint out of plane is quite an easy injection. So you can see again a 26 gauge needle. You can see it entering, and that's my endpoint. There's also suprascapular nerve. Sometimes suprascapular nerve can get impinged. You can also use this for radiofrequency, maybe pulsed radiofrequency in those cases which have got your arthritis is there. Patient doesn't want to get operated. In those cases, this is a volunteer scanning. And suprascapular nerve can be targeted at suprascapular fossa, suprascapular notch. Suprascapular notch targeting, which I've shown here, can be a little challenging. And also, if you're especially new, you may go way anterior and way anterior. it can land up into a pneumo. So that's why what I also do is I use the fossa, wherein I know that my suprascapular nerve has to pass through or below your either from the notch to the spinoglenoid notch. So that area, if I'm able to cover the fossa, I think it should be good enough. I visualize the vessel and I go there. So this is again a bursal injection with in a case of tear. So I usually this so you can see the bursa distending. You can see a supraspinatus tendon. Visualize the this is quite an old video of mine. So slight thickening there. Simple procedure, but sometimes does require expertise. When the patient is thin, it's okay. Otherwise, appreciating the bursa. Most of the times, the problem what we do is, or most of the times when I get the doubts from many of my fellows, they inject above this, but it's actually below. So this is a bursal fat, and below you inject. And this is for the joint. So posterior, I usually started off doing joint injections and sitting position. So it used to be very problematic. So I started with lateral position wherein the patient cannot move. Of course, it's a painful area, sensitive area. So each time you are going to press, the patient will have pain. If you are having the patient in any other position, the patient is going to move. Lateral position with a sort of scarf is a important position in cases when you're targeting intra-articular spaces, like in your adhesive capsulitis or a joint injection or a viscosupplementation. So what we do, we take a lateral position and appreciate with a linear probe, the humeral head, the glenoid, the labrum. Now that is important because here the cartilage, unless and until you've got a nice effusion there, which most of the times you will not get. So choosing the area to locate is very important. So go really slow, visualize your needle well. The needle tip is very important. Once you enter, you probably can give a little bit of saline or you can give a little bit of local to distend the space and and then deposit your injection because you don't want to be injecting into your labrum. Usually in a structure like labrum, it's going to be very painful. You will get a lot of resistance. So ideally, it is better not to uh, go in very close by to the labrum and also into the cartilage area. So joint capsule, when you are going to inject, you will get a small give way. So once that give way is there, you can distend and you can see that the seepage or the effusion is there as sunset sign, wherein your humeral head seems to be pushed down, whereas actually the joint capsule is lifted up. So this is how it is. Your needle is not greatly seen, but you can see the joint capsule, which is the black color area is spreading. You can also appreciate below the joint, the humeral head and the labrum, the cartilage of the top. This is the position which I have. The patient, I face the patient. The machine is on the other side. So ergonomically, you have to be very correct because that will determine if your needle is visualized well. I mean it. So when you are going to position the patient, take your time in positioning. My needling is 5 minutes, but my positioning takes more time. So I position, I plan my procedure. You keep the because you may have to sit for half an hour, 1 hour. So you have to plan up accordingly. In this case, if you can see, I'm just using a 26 gauge 1.5 inch needle. If thin patients are there, it's that is sufficient. Many a times I give and I use, I always tell this on all my platforms that I use a 26 gauge needle as a direction. So as a guide wire leg. So because if you're using a longer, bigger, thicker needle also, which if I have to say most of the common needle I use is because patients are obese. So I use a 23 gauge spinal needle. I feel I have a better control. And otherwise, if patient is thin and moderately built, I use even a 26 gauge needle. 23 is better because you can inject. Previously, we used to inject a lot of volume. Now we have reduced it. This is out of plane. You can do if you are used to it. An out of plane technique can also be done, wherein you are going to see, which you could see in that video which I had shown, where I you can just see the needle as a dot, not the whole needle. So this is an out of plane technique. So You can see there the dot. This is infraspinatus deltoid posteriorly, as we are seeing. This is suprascapular, a demonstration. So you can see, because here your needle is at an angle, you may not be able to appreciate the whole needle. Needle tip is sufficient. You can see the tip there and local spread, and it's very close to the vessel. In fact, you don't need to go at the notch level. As I told you, initially when you start, you may slip and go anterior. So whereas the fossa is fossa is what your target is. So your nerve is actually going to pass from here to here. You can see that. So you don't need to actually target that notch. You can target this fossa. You can target this fossa, which is safe. This fossa is safe because you have the coverage of uh, bone. So you can hit, track the vessel, go near. Even a 26 gauge, 1.5 inch needle out of plane should be good enough. These are my references. This is where I work. Thank you.
Thank you, sir.
Thank you
It was
very
a
much.
very clinical and precise presentation. And as always, you always provide something new to learn. So, without delay, let's move on to a question and answer session. So, I will read out the questions in the comment section and provide your insights to the questions. So, the first question I can see is, sir, if the patient is having severe pain and unable to perform a modified crash position while
Yeah.
scanning supraspinatus, then any other position for complete visualization of the fibers.
No, you don't need to mandatorily give complete, most of our patients will not be able to give, but as much as possible, you can, try to give, maybe not complete cross, modified cross, but slightly also is good enough. And once your needle goes, most of the times you will be targeting the bursa. Once there is a little bit of local anesthetic into the bursa, you're speaking of intervention or you're speaking of examination?
Examination, is asking about
Most of the
examination.
times, most of the times the patient will not be able to give a complete grasp, modified grasp position. But as much he can give, rest it, be gentle. And most of the times it is more apprehension for giving because they have a lot of pain. So you just take the trust of the patient, take a minute to slowly take the position. They will cooperate. And the reason is we do it in a supine position. So supine position, you'll be able to appreciate the tendon also better.
And I think, sir, we can also extend if it is not going for rotation. We can just extend the, it
Yeah, yeah,
also helps.
yeah. That's what I meant. So you
Yes,
just
yes,
take it a little, but try to get the position as much as possible for you to appreciate that proper beak shape.
yes. So coming to next question. How many weeks later after corticosteroid injection we'll have to plan for PRP in case of acute tear?
Uh, PRP definitely is required, but I do give at least 3 to 4 weeks. 3 to 4 weeks,
Okay, sir.
one
Sir,
month.
in periarthritis shoulder, secondary to partial supraspinatus tear, how to plan PRP sessions or nerve block?
First,
Secondary
three
to
times.
partial, secondary to partial tear.
It's most of the times there is involvement. So I don't do any procedure without PRP now. I ask the patients, but I'm going to treat the adhesive component first and then the PRP for the supraspinatus. Most of the times it is supraspinatus which is involved. You many a times may not require a supraspinatus as such, but a little bit of intraarticular and little into the bursa because the PRP in itself too much into the tendon, little bit of fenestration, slight about half an ml into the tendon. This is my experience completely. It helps with the bursa. The rest, so don't try to put all 5 ml or 4 ml into the tendon. It might be really very painful. So follow it up after a proper release. Let them start movement rehab and then you get it done.
So next question is, what will the findings in calcific tendinopathy? Do any management other than barbotage work well?
No, sometimes if it is, it might be a large calcification, but it might respond well to rehab and even, bursal injection. And many a times, if the pain is very severe, that's the time you plan for barbitage. In especially those cases where it is in that stage where it is more of a paste like, where you don't have simple, as I mentioned in my talk, if you don't have a posterior acoustic shadowing below it, usually that is the stage where the patient is going to have a lot of pain. And barbitage, of course, as you know, the needle you're going to use is not going to be 23. You have to use a larger bore needle, larger gauge needle, smaller gauge needle, sorry, 18.
Yes, sir. So next question is there any demarcation between a near total full thickness and massive supraspinatus tear?
Yeah, see, as I told you, there is a full thickness tear there, massive completely it is avulsed. Whereas a full thickness tear can be at, that's the reason I told you short and long axis has to be taken. So there is no demarcation as such, but a complete retraction of the tendon will be there in a massive tear.
Okay. Have you ever encountered motor weakness while performing suprascapular nerve block at spinoglenoid notch?
Yeah, definitely it will be there. But that spinoglenoid notch, that's the reason, no? At spinoglenoid notch, we do a radio frequency. The radio frequency is not close to the vessel. The radio frequency is very close to the the hill area before the glenoid. So it is not supposed to be within or close to the vessel. It is more distal to it and closer to the joint, because those are the articular branches which you are covering. The infraspinatus branch has left at spinoglenoid notch. So you can give an injection, there is no problem. But I believe if you are targeting for the articular branches for radiofrequency, it's always better not to be close to the vessel.
How much amount of injected do you inject for hydrodilatation and what does the cocktail consist of?
See, recently we had a talk in ICRA, and I think everyone must be knowing Dr. Madan Pandian. So, Sir was presenting on anterior approach. He says, he has done a study. See, there are a lot of studies coming up. Initially, when we started, we used to put 40, 50, 60 ml, 100 ml, some people used to put. So, the concept was of completely rupturing the joint capsule. But I have a funda of about 30 ml. 20 to 30 ml is maximum which I'm injecting in posteriorly, anteriorly 10 ml, and that is what he also compared with a hybrid technique where he injected to what level the the joint capsule could, we could reach the posterior joint capsule from the anterior side. So it was about 9 ml to 10 ml in about I think 20 patients. So anterior approach is good approach now, where we are injecting close to the your rotator cuff interval, in the rotator cuff interval, and about 10 ml should do good, because here you are also going to get some resistance. Posteriorly, maybe 20 25 ml should be good enough.
This the next question, sir, is how to manage patients of adhesive capsulitis with supraspinatus tendinosis and after hydrodilation is done, but
Not
patient has
ma-
pain on abduction and tenderness is there.
okay. So not mandatory that every patient with adhesive capsulitis, as I told you, tendinosis might not respond greatly to PRP. So for that reason, you first, there was another talk which recently we had 2 3 MSK conferences. So the ideal thing is that there is not one pain generator which you can target in adhesive capsulitis. You will have to target multiple areas to get good results, and this is what I have also learned. So go on your sonopalpation, your examination. Very important. So where you feel the pain is originating from. So most of the times where I inject is posterior. It is very close to me. I somehow feel that posterior joint, hydrodilatation has helped me, and I also target the bursa. So usually the tendinosis part also gets covered in that. Maybe you can repeat as a bursa injection. I have not done it, but those cases which are little resistant, I do give an anterior approach injection, maybe after 2 or 3 weeks.
We are getting a lot of questions. That's good
Yes,
thing
that's
actually.
okay. That's
So
okay.
next question is do you inject PRP or any other intervention for SLAP 1 and SLAP 2?
May not help, but you can try. I have given bursal, labral tears. So small tears have worked well, but I think slap is more of a surgical approach.
Do you give LRPRP or LPPRP for supraspinatus tears?
You can give, leukocyte rich for tendons. It's more joint which you have to give leukocyte poor. Otherwise, the patient will have severe pain. But remember one very important thing, that when you are actually going to give a spine, any tendon of your shoulder, please don't pump in a lot of volume. Imagine thinking that it's going to help. Maybe fenestration helps more. And if you see, I keep posting. So it's only, I just do that. I just tap so that a few drops keep going everywhere in that area when I'm doing fenestration. So maybe an ml into and around in the bursal, the rest of it.
Any experience with GFC or hyperacute serum?
GFC I have used for plantar and lateral epicondyle, but not for shoulder. I'm happy with mine. Yeah.
Okay, sir. I have one patient in whom I did hydrodilatation, but after 1 month of relief, patient has pain and tenderness in the supraspinatus tendon area.
Maybe
So
not
what should
supraspinatus tendon alone. Sometimes what can happen is inferior glenohumeral ligament edematous. It can be very resistant to, even I have had a few patients. Get your MRI if you have not got it, and that will actually get an insight. It's very, very important for us to mention to our patients that there is limitation of every intervention. So I feel
exactly?
that that's you'll be safe, and it's not worth that that stress. To be frank, so always mention that. See, bhai, I'm doing this intervention. 70% works really well, 20% decently well, 5 to 6% or 10% may not work. So this is very important for us to mention before we actually take in any intervention.
So do you give steroids after barbiturate, and can we give PRP instead of steroid after barbiturate?
No, steroid, yes, but PRP, no. So what is going to happen is there will be a little bit of spread inside the bursa. It is going to cause severe pain otherwise if you don't give. You have to give a small dose of steroid in the bursa.
How to demonstrate displacement of bicipital tendon from the groove?
Dynamic scanning.
Yeah,
Beautifully. You can appreciate it. One of the video I think I had posted, it was directly into the subscap. So you can definitely appreciate, not that
rotate.
we are external rotation and dynamic testing, it will definitely be illustrated well.
And do you prefer anterior or posterior approach of hydrodilatation? I think I have already
Anterior.
answered.
Yeah, yeah, yeah. Anterior is definitely good, but it's my preference. I do posterior more.
I come across a talk on microembolization of arteries supplying shoulder for shoulder pain by a radiologist. Any experiences with this?
I don't think that is our scope. But
Yeah.
yeah, they do it. But there are a lot of studies which have to be done. The same thing can be done for genicular artery. It is more commonly done for genicular artery actually. So that gelatin, they do. So that's the reason why I have also seen that when we are doing genicular artery or nerve ablation, whenever I enter the artery, I actually get better results because even that artery is also destroyed. So the pain is coming back for the patient also as the arteries regenerate otherwise. So that embolization is also happening there. So, but I have not done by myself. That's, I think, they enter through the femoral artery.
Now, how many times do you perform hydrodilatation for periarthritis? How many
Um,
times?
I have not repeated uh, hydrodilatation for most of the patients. As I told you, only for a few patients, anterior approach I do who are resistant.
SSNB and supplementation with axillary nerve block. Is it better for pain?
I have to not done, but I nowadays I don't even do suprascapular nerve. What I also do is maybe a little bit of local inside the bursa before PRP helps my patients. Small amount of bursa is a huge space.
Yes.
Half a cc into the bursa. Give about 5 minutes or 10 minutes. Patient tolerates well.
What is the best way to manage supraspinatus stenosis in your clinical experience?
Difficult. It is difficult, but you can give a bursal injection. I think that's maximum what we can do. And
Any
we
experience with collagen injections? Abroad, they are doing collagen injections instead of PRP, especially in Korea.
must be, but I
Collagen.
think it is under research. It is
Yeah.
not too commonly done. I have not done it.
And someone has said, happy Teachers Day to Iker sir. The best
Again,
teacher in depth insights always.
thank you, thank you,
Yeah,
thank you.
definitely.
Who is that?
So one more question from my side.
Yeah.
Uh, Whenever we have a bursal surface tear, the fluid is communicating with the tendon as well, within the tendon.
Yeah.
Okay. So in that case, do you give steroids? Because it will be going inside the tendon also.
Maybe a
It will,
small dose, but ideally, no, if it is bursal surface tear, you can directly go for PRP as well. So one more thing, what helps in, which I probably didn't mention, is prolotherapy. So if at all you have, just put about 5 to 10% of dextrose, a little bit of local into the bursa, give some time, start a little rehab, and put a PRP later on. I think that's a good thing.
okay.
So I think prolotherapy, giving about 5 ml, it should do good, man. I have done for many of my patients. So to come out of that thing of, and even I think Dr. Madan sir also does a lot of prolotherapy inside the Barsa.
Yes. How many sessions of prolotherapy? I think it's same for PRP.
Single session you can do, then follow it up with PRP. No, anyways, we are giving the more better one in the subsequent session. The basic idea is to give, the pain shouldn't increase. That's the idea. That's it.
Yes. So I think all questions are covered. And thank you so much, sir. You have replied beautifully to all the questions.
Thanks, man.
And thank you all the audience. And thank you, Dr. Viker, sir, for being there to teach us in very
Thank you. Thank
common
you.
topic.
Thank you, Debashish. Thank you for the invitation.
Thank you, sir. Thank you all. So we can wind up, I think.